Okay, hi everyone. Thanks so much for joining our panel tonight, Saving Primary Care in the United States. It's an interdisciplinary dialogue. My name is Kiara. I'm a physician assistant at Fairhaven Community Health Clinic in New Haven, Connecticut, Fairhaven neighborhood. We are joined tonight by three very awesome panelists. Um, I will start by introducing SMA, the Social Mission Alliance, who's kind of organized this talk tonight. Thank you for anyone who's come that's kind of outside of the organization that's stooping into this conversation. We're excited to have everyone tonight. So, like I said, I'm Kiara. I'm also a project lead of the Health Equity Scholar Guide at Social Mission Alliance. This is a survey for students interested in sharing about their health professional training institutions. SMA um, Student Assembly is a forum for health professional students interested in using their talents to advance health justice and social mission. So that is the section of SMA that I fall under and am staffed under. So we seek to do this by supporting mobilization of health profession students in voicing their concerns, building community, exchanging ideas with other students on how to advance equity in education, research, service, policy, and practice. So we all know primary care is behavioral health, it is women's reproductive care, it is abortion care, it's dental care, it can be specialty medicine at times. In all of its forms, primary care is crucial to ensuring the health of a nation. However, in the US, too many people are going without basic primary care in all of its crucial forms. And we know this is due to an array of factors, including but not limited to inaccessibility of health insurance for the working poor, because Medicaid has yet to be expanded to all states in this country, Obamacare. Inequities in Medicaid reimbursement that inform decisions of providers not to take certain types of public insurance, pay disparities between primary care fields and medical subspecialties that make these roles less appealing to trainees in the pathway. There's even hierarchy of prestige within training programs at academic medical centers that consider pursuing primary care fields a wasted opportunity. There's so many more. We will talk about all of the ways that primary care is stymied, but tonight we'll like to focus on the good things that people are doing, especially as it relates to our panelists. So efforts are being made on multiple fronts to address policies and cultural norms standing in the way of realizing primary care for all. And it should be for all and it should serve all in this country. So tonight, our goal is to break down the walls that often silo these different efforts from one another by bringing together three individuals representing unique approaches to rescuing primary care and expanding access to care in the US. So, with all of that, it is my pleasure to introduce Brian, Hannah, and Nishmi. Um, Brian is an MD, MPH. He's a family physician, assistant professor in the Duke Department of Family Medicine and Community Health. He graduated from UNC Chapel Hill, earned a master's of public health at the UNC Gillings School of Public Health. He completed his family medicine residency at the Mountain Area Health Education Center Family Medicine Residency Program in North Carolina, Asheville. Subsequently, Brian was the 2019-2020 Robert L. Phillips Health Policy Fellow at the Robert Graham Center in Washington, D.C. Currently, he's an associate director of the primary care leadership track at Duke University School of Medicine and co-director of the Health Equity Policy and Primary Care Fellowship Program at Duke, as well as the Duke Public Health School. Uh, Brian is we are very excited to have you. He enjoys working with medical students, residents in the clinical setting, discussing health policy, advocacy issues. Other interests include preventative medicine, culinary medicine, prenatal care, newborn care, and environmental health. So thank you, Brian, for coming. We have Hannah Hamdi, MPH. She is a board member of Primary Care for All Americans and currently pursuing an advanced practice degree in nurse midwifery at Yale University Nursing. And Ms. Hamdi holds a Bachelor of Science in Biomedical Engineering from Rutgers and an MPH from Columbia. She's worked primarily on research studies and public health projects around the world, such as child-friendly spaces evaluation for Syrian refugees in Jordan, an assessment of palliative care services in Senegal, and a health workforce strengthening program evaluation in Uganda. Closer to home, she's also worked as an epidemiologist at the New York City Department of Health, in the Department of Family and Child Health, and at Planned Parenthood as a data analyst. So she is committed to creating a world where everyone has equitable access to preventative and primary care. So thank you so much, Hannah, for joining. And last but not least, we have Nishmi. She is a community organizer and movement strategist with over 20 years of experience from Pennsylvania. She's a co-founder of Put People First PA, which is a working class, statewide, base building human rights organization. And she's the chair of the Pennsylvania Poor People's Campaign, a national call for moral revival. We are so excited to have you here, Nishmi, because we love to have community organizer perspective in all of this. We would hate to have a Zoom call of just MDs, healthcare workers. No offense to all of us healthcare workers, but we are so happy to have you. So thank you for giving us some of your time tonight. These are our three panelists. And with that, please add anything that I did not introduce for you three. And we'll move to questions shortly after that. So please add any introducing remarks that you may have. No?
I guess I'll hop in. Nothing to add. I think I appreciate the introduction, Kara. I just want to say I've been admiring this organization from afar. I know you guys had a get together in Durham, and I was very sad that I could not make it because of clinical duties. But I admire you guys from afar, and I'm excited to have this conversation tonight.
Awesome. Definitely come to the next conference. We'll all be there. All right. So we'll jump right into questions. Audience can also overtake my questions that I have for the panelists at any point, but we'll begin with asking each of our panelists to have give us like 10 minutes or whatever amount of time you feel to explain what experiences motivated you to get into the movement to expand healthcare access and primary care. What about that experience informs the tactics you're using right now? So kind of tell us how you got to be where you are.
I'm happy to hop in first. I guess my interest in primary care probably started in medical school. I maybe even before that. I came into medical school thinking I wanted to do pediatrics, and quickly realized that I enjoyed a lot of everything. It didn't hurt that when I went to medical school at University of North Carolina, there's a lot of um, primary care physicians, whether pediatrics, family medicine, general internal medicine, and positions of leadership. So there's a lot of face time between students and folks in the primary care spaces as you're going through the curriculum, even from day one. So I think, as we think ahead in terms of thinking about how to expand, the primary care workforce, I think part of it is leadership, right? Like having folks in positions of power with lots of face time with the future of the healthcare workforce that value primary care. So I think it's that kind of interest kind of blossomed in med school. Um, and then I saw a lot of those same folks getting their public health training across the street at the Gilling School of Public Health when I was there. Um, but I think when I started to notice the issues with primary care access, it's hard to see that sometimes when you're kind of at this big academic center. And I think started learning more about it through my public health years. But in addition to that, really when I started practicing as a resident in Western North Carolina, part of our work, it was doing home visits to kind of outlying communities that might be an hour more away from our clinics in the middle of away from Asheville, North Carolina, which is, at this point is 120,000 person city essentially in the middle of Western Appalachia in North Carolina. So driving 20 minutes even outside of that metro area, you can get rural really quickly. And it kind of started making me think about all the people that would never make it to my clinic, all the people that already struggle to get to clinic, but thinking about I can't even imagine how many people out there need our help that doesn't even make it there, right? Or who needs access but can't get there or don't have means to coverage, transportation, et cetera. So I think that was kind of the aha moment to so to speak. And I think part of the reason I gravitated towards the health policy fellowship in DC at the Graham Center was to try to think about those questions kind of at a bigger scope and trying to better understand what people with primary care backgrounds are doing and figuring out whether that was something that I was interested in getting involved in. And I think it was an incredible experience. I met a lot of really amazing folks like y'all working on similar questions. Um, but I ultimately ended up at Duke for a number of reasons. Part of it was I think selfishly I was interested in an opportunity where I could balance and use my clinical skills in practice, but also be able to kind of feed that interest that existed outside of the clinical setting, whether it's working with medical students thinking about learning about basic foundational health policy concepts, strategies and advocacy, provide mentorship, sponsorship for students and learners. And so I gravitated to medical education partly for that balance to kind of feed all the things I was interested in and an opportunity to do that. And I kind of fell in love with the area when I was in medical school and I was kind of itching to come back. And circling all the way back to the beginning, talking about, you know, mentors and folks that you look up to at the med school level, at the training level. One of the folks I admired the most when I was a student at UNC became the chair of family medicine at Duke, and we had kind of kept in touch through my years of training and reconnected and kind of shaped an opportunity and a job that felt like met my needs, but also the needs of the department and the institution. So I'll pause there and maybe I'll hand it off to Hannah.
Thank you so much.
Thank you so much, Brian. That was such a lovely story. I love how it came full circle for you. Um, I think for me, my interest in pursuing like system level primary care work comes from my own experience. As someone who needed primary care who was uninsured for a long time during childhood, because I come from a low income family. We were lucky because my grandma is friends. She was friends with my pediatrician, and so he would see us for free. And they're both. I'm come from a Palestinian family, so she's Palestinian, he's Palestinian. They come from like similar backgrounds, similar communities, so he's willing to do that. And he was willing to do that for a lot of people who are in need. And his like clinic is always like at capacity with like long wait times and stuff like that. But he was such like a kind and generous person. And so that was like pre ACA, pre Affordable Care Act. And even since then, there's still a lot of people who don't have access due to their socioeconomic status or even due to their location, like Brian's story. Like, there are so many people just geographically, like, why would they even have the ability to access primary and preventative care if it's not something that they can go to routinely or reach, just transportation wise. So yeah, so that's kind of what got me thinking about these things deeply. And during my time in public health school, like public health has kind of all the answers to all the things that we struggle with. I don't want to say that lightly, but I think like people in public health think really deeply about what preventative care means and should look like for people, but it is chronically underfunded. And on purpose, it's by design. We have a capitalist healthcare system um, that spends like more on lobbying than they do on care, right? Because it's run by insurance companies. Anyway, that's like a rant I can go on later, but it's not really prioritizing people, right? Kind of like what you said in your intro, or somebody said it, like People Over Profit. I think that was her organization actually. So, anyways, my personal story informed why I like to do primary care work and organizing in my like free time. So yeah, so I got involved with primary care for all Americans. I'm working on a degree as a midwife to work on reproductive care because that is a really important part of primary care that doesn't always get included in primary care when we think about it. So I really appreciated that you mentioned behavioral health and reproductive health care as part of that. Um, so yeah, I don't know if folks want to learn more about me or my journey, but I feel like that's my like where I enter this discussion a little bit. Oh, and I'll pass it off to Najmi. I might be saying that wrong.
Nijmi. Yeah, no, you got it.
Najmi. Okay.
Nijmi, yeah.
Yay. Okay, great.
Hi, everybody. Thank you. It's good to be here tonight. I appreciate the invitation. Uh, yeah, I'm Nijmi Zakia Zarinko. I live in central Pennsylvania. Um, and I'm a co-founder, as was mentioned, of Put People First PA, and then a national network that we launched called the Nonviolent Medicaid Army. And so I come to this discussion not as a healthcare worker, but as a person who has been involved in the movement to end poverty for about 25 years. And about 12 years ago, we were looking, some folks I was working with and I, having come through a number of different organizational experiences in the movement, came together to envision starting a statewide organization in Pennsylvania that would bring people together across the urban-rural divide, the party divide, the racial divide. And it was actually, we thought a lot about what would do that and what would have the ability, what kinds of issues and things would have the ability to unite people across these historic lines of division. And healthcare is an issue that does that. And it's really for us more of a strategy. It's not simply an issue. Um, and over time in our organizing in Pennsylvania, we came to focus on people who are on or excluded from Medicaid, including myself, my partner, and many people in my family, and over 3.5 million people in Pennsylvania, um, who, as we're working on this movement to end poverty, some of our fundamental assumptions are really that, change comes from below, it doesn't come from above. And so I think that's been true in history. I think that's sort of true in what we've studied. So we're really focused on building a base of people who are on or excluded from Medicaid as kind of the leading social force or the group of people in society that has the most to gain and the least to lose from a fundamental transformation of society. Because I think that the healthcare system is one example of, a system in our society that is built on, profit over people. And that's going to be true of every system in our society. But health is really a deeply felt need and thing, right? Everyone has a body. We all have a body. It's something that we all need. And it's something that we have in common, right? Regardless of the other ways that we are different or purposefully divided, it's very powerful, uniting issue. And then when we look at the system that we're up against and the people who uphold it, healthcare is also really interesting because it's a huge site of capital accumulation. It's a sort of a risk-free, there's many around the world, sort of global capital sees it as a place to kind of park their excess capital. And at the same time, the structures and the powers that be don't really have any solutions, actually. There's small little interventions that they talk about, but they're not actually dealing with the root of the problem. And so it's again, a really powerfully uniting thing for organizing this group of people that in the Poor People's Campaign, we talk about 140 million people in the United States who are poor or near poor, one paycheck or healthcare emergency away from poverty. And that's almost half of the country. And so we see this group of people as a potentially really incredibly powerful force if they can be organized. And healthcare is a really powerful mechanism of bringing people together. We've been fighting back against the Medicaid cutoffs that have happened over the last year. 25 million people across this country have lost their Medicaid as part of the quote unquote unwinding after the pandemic. Whatever you call it, it has resulted in 25 million people being cut off of their health care. And so that's something that we have been organizing around, one, helping people fight back those cutoffs. Everyone has the right to an appeal. So we've been doing a lot of that. That's a really powerful tactic, appealing those cutoffs. We've helped a lot of people keep their health care. In fact, in Pennsylvania, in our organizing work, we have a success rate of 93% of keeping people on their health care when filing appeals. So yeah, I mean, lastly, I would just say that primary care, I think as we're seeing, primary care and the care of families with newborns and this kind of thing is all is not as profitable as other kinds of care. It's not as profitable as certain kinds of chronic illness, not as profitable as areas where technology is being applied in particular ways. The birthing process is not something that can be regularized. And so I think a lot of capital is withdrawing from these areas that are actually going to be critical for helping us be healthy. And they're invested deeply in the side of healthcare that is like after we're really sick, after we're really sick and we need chronic, care and surgeries and all this kind of thing. And so it's actually, very much a sort of death dealing system that is really trying to profit as much as possible off of our sickness and death. And so there's a lot to, to motivate us to change that.
Wow, thank you for those beautiful kind of glimpses into just a little bit of what brought you into this space. I have a quick follow-up question before I will give this to the audience because I don't want to hog you guys' time. And I know that other people might have questions. So we have, Brian in the institutional space now, in med ed space, which we're so happy someone like you is in medical education. And we have Hannah, who's currently a student, but also part of the Saving Primary Care or Primary Care for All group. And then we have Nishmi, who's on the ground, really doing this community organizing work. So I would love for all of you to think about, you represent different strategies for moving the needle. How do you see some of your efforts completing each other towards the collective goal? What are some of the obstacles to better collaboration that you've seen? How do you think they can potentially be overcome? How could all of your different strategies kind of better synergize, if you can think of some ideas there? Hannah, do you want to go first and also tell us more about some of the strategies about that primary care for all Americans?
I feel like I don't have all the answers to all those questions, but I
I
will.
know.
Feel like we're all trying to figure those things out. And I think just to your point about strategies, I think having overlapping strategies is not necessarily a bad thing in a space where there's a lot of work that's needed to be done on like a community level, institutional level, etc. So So yeah, so some of our answers might overlap, and I think that's actually a good thing that we're all kind of like working on these things. I think there does need to be more like communication across the work that we're doing so that we're building and not like reinventing the wheel kind of thing. But I don't know if I have an answer to that either. Maybe my two co-panelists do. I will say primary care for all Americans kind of focuses on a state approach to primary health care. We're like kind of over, I'm maybe overstating this, but like we're a little bit over the federal government and what they're actually willing to accomplish for people. And our focus is really on states and to work with state governments and communities, right? Because communities make up counties, make up municipalities, make up the state. So that's kind of like our focus. We just published a playbook, which is supposed to be like a guideline for states to use to mobilize folks and to get them involved in working toward primary care for all Americans. It's up on our website. Um, so yeah, so on the state is like, I think this might not be true of like how every state operates, but making it a state level responsibility makes it also so that there's like ways that we can influence like the state's need for like healthcare workers and like getting more students in like healthcare education. And then once people are in healthcare education, how are they getting to communities that need them, et cetera, et cetera. So that's kind of the focus. And also because funding for Medicare, or not Medicare, but Medicaid comes through states, like that's kind of also what we're kind of also trying to address. Um, and then we're also trying to shift our focus from payment reform to creating a delivery system. So like a healthcare delivery system that actually like is geographically equitable, is equitable across race, ethnicity, like other intersectional diversities, right? That does deliver the care to the needs of the people, that is well designed, well deployed, primary care based delivery system. So that's like kind of our one of our other big goals. Um, and then arguing for primary care as an essential service, just like your clean water supply, just like your garbage pickup, just like your public schools, just like your public library, just like your roads. Primary care is that necessary. And the cost of providing primary care like that is actually similar to or less than the cost of those services when measured per resident per year. It is like the more cost effective thing to be doing. And then also arguing for primary care as a critical aspect of public health in kind of like what I mentioned earlier. We get the best public health outcomes from having primary care for everybody, from ensuring people get the care they need, their preventative care, that they get like routine checkups and management for their chronic health conditions so that we don't have people in the emergency room getting amputations for diabetic neuropathy when we could have controlled their diabetes just if it like they had access to a clinic to come there that we could have reached them, right? So like having a system where we think about it in like more that way than the way that we're just like, oh, we need to like reform how we pay for healthcare, which of course we do, which is its own big, huge issue. But that's kind of like the way our platform is designed and the way we're trying to think about it and push the needle forward. But again, as I said earlier, kind of like every strategy is needed here because it's a huge issue and it has a lot of layered problems. Like, why do we gatekeep medical school from people who want to go to medical school? Why is it so expensive? Why is it an extra 4 years after college? In every other country, medical school is a bachelor's level degree, just a longer bachelor's degree. Same for like midwifery. Midwifery here is a graduate level degree, but in most of the rest of the world, it's a bachelor's level degree. Anyway, I could go on a lot of rants, but I'll stop.
That was awesome.
Um,
It kind of segues into something I had for Brian, which is like
okay, great.
No, that was awesome, Hannah. Thank you for kind of describing that base, those playbooks that they use. Um, and then I guess it kind of just reminded me of something Brian was saying, where you are leading this health policy fellowship and also an associate program director of the Duke Family Residency. How do you motivate, like how was your experience with your upcoming residents and your students? And you mentioned something about like teaching them advocacy tools and having them get involved, so tell us a little bit about how that kind of intertwines and your vision for that.
Just to clarify, I'm not involved in the residency. I help with there's a primary care specific leadership track within the School of Medicine. So there's somewhere in the neighborhood of 8 students per class in a 120 person class, just to give you a ratio that get admitted directly to this primary care leadership track. So it's a parallel track to the traditional curriculum that exists at Duke. So they're taking a lot of the same courses, but they just kind of have additional content, a little additional opportunities for different workshops or different seminars, mentorship access, community engagement project that runs through their time there. So I will say, like, zooming out for a bit, like bird's eye view, I think my perspective is probably, and my goal and my vision for what I hope my impact is here is I kind of have it through the lens of what I experienced as a student and what things helped me and fostered my interest in primary care and a career in primary care. So knowing how important it was to that visibility of faculty in primary care in my early days, try to think of ways to get out of those silos within different departments or residency programs and be more visible very early on in the undergraduate medical education time, whether that means working with different health professional learners, sponsoring my other faculty in my department to get more engaged within the medical school. I think that's one approach. I think PCLT, that primary care leadership track, was attractive to me as an opportunity to be engaged with folks who already think they have a future career in primary care, because I felt like when I walked out of med school, I had wished I had a little bit of better understanding of the alphabet soup that is policy stuff, right? Like all these acronyms and abbreviations that I was unfamiliar with, how insurance systems work, Medicare, Medicaid, what's the difference, right? Like something as simple as that. So when I joined the PCLT leadership team, my hope was to kind of raise the floor of everybody's understanding that goes through that curriculum, that pathway, to kind of just have the foundational knowledge and understanding to be able to then go out and participate and work like the things that Najmi's team's doing, to kind of be able to interface and be able to conversate with those organizations in a meaningful way when you actually understand the language and how to be useful. So those are kind of the bird's eye view perspectives I think I have about how I hope to have impact. And then, further down in their training, whether it's residents or even fellows who are interested in getting more involved in the primary care space, it's really, I feel like the folks that do a lot of this work, we're probably going to see each other over and over in a lot of different places, in a lot of different spaces. And so encouraging them to go into those same spaces, make those connections, collaborate, push them into opportunities that might align with what they're interested in, continuing to sponsor folks. I think those are the kinds of things that I thought were helpful to me in my path. And I hope to be kind of that person for a lot of learners.
That's beautiful. We're glad someone like you is in the education space. So those 8 students are lucky to be part of that pathway. Wish it was a normal baseline for all of the medical students. I found that in my medical curriculum. That would be awesome if everybody kind of had that baseline understanding. And it's true. they throw people kind of into medicine sometimes, and then you find out all of the social workings afterwards or the policy workings afterwards, and people can feel really exhausted from that lack of knowledge when they jump in. So thank you for that. And Nishmi, how do you see some of these different efforts synergizing, if at all,
Uh,
silos?
yeah, we actually work with a lot of healthcare workers, and we have a lot of healthcare workers in our base. Um, we do these people's clinics. We do these free kind of half-day people's clinics all across the state, and now in 10 states in the Nonviolent Medicaid Army. And that's a great place where healthcare workers join with us and help carry out those clinics. They're built on the foundation of the legacy of organizing in the Black Panther Party, the free breakfast programs, and also health clinics that they did, and what they called projects of survival or survival programs. And so those have been a really great way to work together with healthcare workers. And then I think on state level policy, one of the things that we're doing in Pennsylvania is pushing for a public health care advocate at the state level. There is currently no state office that really fights for and defends the healthcare rights of everyday people. We organized for several years to pressure the Pennsylvania Insurance Department to do some things, and we got them to do some things. But in the course of those campaigns, we also learned that part of their mandate is making sure that insurance companies stay in business, and so that's kind of fundamentally at odds with ensuring that our healthcare rights are defended. And so we're fighting for a public healthcare advocate. And I think that on all of these levels and different kinds of interventions, folks who work in the healthcare system really know what's going on, just as patients and community members do as well. And so I think it's really important to kind of come together across that divide as well. Healthcare workers, we consider healthcare workers to be part of the working class, not a separate category of people. And so, we feel that everybody in the working class, has a stake in a different kind of healthcare system. So I think there's a lot of really important opportunities to come together and collaborate.
Thank you all for those answers. I think at this point, I'd like to open it up to the audience. I know I could ask a bunch of questions to each of you because you guys have such exciting things that you're part of. But I will open it up to the audience to ask any specific panelist questions or to the general group.
Like Rashmi has her hand up. Rashmi, go ahead.
Hi, can everyone hear me?
Yes, hi Rashmi.
Hi, everyone. So glad to be here tonight. Yes, sorry, my AirPods are being funky. Thanks. This is really such a great conversation. I'm really happy to be here tonight and to hear just like the diversity of experiences, and just hearing all the amazing work that y'all are doing in your corners. It makes my heart really full. So I know some folks on this call, but my name is Rashmi. I'm a second year osteopathic med student at AT Still University out in Arizona. But I'm currently completing my second year of medical school, and I'll be here in Chicago for the last 3 years of my medical school because AT Still has a very unique curriculum that's very mission oriented and focused on actually building the DO primary care workforce out. And so they place us at community health centers starting our second year, kind of scattered across the country, depending on where we get assigned. So I'm really grateful to be part of that kind of like mission and wanting to contribute to the primary care workforce. So I've been, as a part of my second year, I've been at, sorry, I cut out for a second. I've been at my CHC here in Chicago. And one thing that I've been noticing and something that's been coming up a lot in conversation is going back to the question, or one thing that Hannah, you brought up is how do we kind of like incentivize students to become primary care docs and really incentivize people to go into primary care. But one thing that's been coming up a lot is just how health systems are not necessarily really incentivizing that, because when it comes to hiring, people want to hire NPs or advanced nurse practitioners or nurses or whomever. And then, they schedule like so many patients on their service. And even at our clinic at Near North, we have one of our smaller clinics actually doesn't have a physician at all, just because we're like super, super understaffed and we don't have enough physicians that are at, in the health system. And we have a lot of NPs, which is great. I'm glad that we can still continue to see our patients. But what do you do with that, right? So I'm curious to hear kind of what your guys' thoughts are, and but there's a lot of like advocacy that needs to happen both at the state level. But one thing that's been on my mind a lot, especially with the election results and just thinking ahead to what our FPHC funding is going to look like and how that landscape is going to change. So just curious to hear what y'all have to say about that.
I will kind of, since you mentioned my comment about like healthcare training and access, two things. One, NPs are trained primary care providers. I know it feels like a gap that there's not a physician at that clinic, but they're comprehensive primary care providers. I say that just to also explain that NPs are kind of a role that was created because of the lack of primary care providers in this country, which like we know we don't have enough providers for our population. And instead of going and like being like, oh, we'll make medical school cheaper, we'll like expand medical school class sizes, we'll like increase STEM education. Like instead of doing those things, we were like, oh, who can we hire instead to make like a doctor but cheaper? Which like I don't want to like hate on any NPs. And I'm in a school with a bunch of NPs who are great providers and care so much. And I know they're going to be great providers. And like, and my faculty are really knowledgeable and they work with doctors and other NPs and PAs and all the stuff. But like, we created these other pathways into healthcare to expand like healthcare staffing without like really deeply thinking about like, oh, well, we could just make becoming a doctor a lower barrier to entry, but it doesn't service us for whatever reason. That like maybe it's like benefits the medical schools to charge this much in tuition, and then benefits insurance companies to make it so that like they don't have to pay a doctor for primary care, they can pay an NP instead, and like doctors can do specialty care. And then they often push, I don't know, I'm not an expert in this, and Brian, please correct me if I'm wrong, but like then they push doctors to do specialty care rather than primary care so that they can pay off their loans. It's like there's a lot of things that are wrong in like the way we like conceptualize healthcare workers and like even physicians. Like in a lot of the rest of the world, like physicians are not paid as highly as they are here because they're considered like everyday primary care workers, like in the NHS in England. Like, and I don't think I'm not necessarily advocating to pay doctors less or whatever. Like, please, nobody hate me for what I'm saying. But like, if we think about it globally, there's a lot of really systemic issues that I don't know if I'm really answering your comment, but I wanted to clarify that about what I said. I don't know if I answered your question.
No, you did. You're absolutely right. Like there's so many layers to it, and I do wish more like the medical education, like financial model system incentivize more people to go into it, right? And like I'm lucky to be at a school where, like I said, it was very like mission aligned, and a lot of my classmates are very much kind of in that mindset. But I also know that that's not necessarily the norm in a lot of places, and a lot of it does have to go back to the financial cost of medical education for sure. Maybe Brian has more to say, because I know you're in the medical education space. Sorry, not to put you on the spot.
Yeah, I think there's not an easy answer to that question, right? I think one of the pickles that we're running into health system wide, like if we think about the U.S. health system, it's not just the shortage of primary care, right? It's also the maldistribution, right? Like in the areas where there's higher saturation of populations, there's more people that want to live in those places too. So in some ways, some places might be oversaturated with access to providers. I think the question is a little bit more complex than that. But I think if you're trying to zoom into your own personal experience as someone who's going through medical training, trying to figure out how do I hold my value, right? Like how do I hold my value to the health system? I think maybe um, I'm silly about thinking this way, but I think people are going to realize that, folks that have that primary care training where you have a broad scope, breadth and depth of ability, I think that's always going to be a value to the health system. Maybe I'm going against the grain here and the fear that exists out there, but I feel like there's so much value that we bring to the health system and to our patients that we are important parts of this process and this pathway. But I agree with what Mark kind of put in the chat. Like, we need some investment into primary care to sustain that, right? And so some of the work that you're thinking about doing or focusing your energy on, like whether it's advocating for those so that when you finish training, there's a place for you to land. But I think if you have some flexibility in your, everybody's personal situation is obviously different, but I think if you're seeking opportunities to be able to practice that broad spectrum of care and to make a difference to a community, I think the primary care training suits those needs well in a lot of places that are suffering the burden of that maldistribution of primary care providers. So for example, where I trained in Western North Carolina, about 60 to 70% of every class that I graduated with through my program stayed in the western part of the state, which beyond the Asheville metro area is quite rural quite quickly. Part of it is I think we fall in love with the mountains and the beauty and all that, but I think part of it too is like it's serving a need, and it's also an opportunity to kind of showcase the things that you learn to do and being able to wear multiple hats as a primary care trained doctor. So for a lot of us that train in family medicine, there we had a lot of a pretty heavy inpatient training. So a lot of us that graduated remain practicing inpatient, outpatient. And what was cool there, and I think this is kind of some of the cool local solutions that people try to come up with, is there are areas like kind of satellite hospital, like more rural or critical access hospitals that are struggling trying to recruit pediatric specialists or OB specialists to come to their location to keep an L&D open or keep like a stabilizing special care nursery open to kind of care for those higher level acuity patients. But they can hire a family doc, give them extra training, who can do both those roles in one position, right? So like I have colleagues who graduated, took on these jobs to cover these hospitals, and then the hospital system let them have 50% of the time while they're working as an attending to go back and get additional ICU training for NICU stabilization and to learn C-sections. And so they have mechanisms. I think if you're trying to be creative, you just have to find those opportunities if you're interested in doing something like that. But those exist. Like they're out there if you have some flexibility. Again, everybody's personal situation is different, but I think there are systems and communities are trying to think creatively, just tackle some of these problems. And I think having a broad-based training in primary care makes you, I think, a valuable commodity in those contexts.
Follow-up question from the audience. We had a question from Morgan. Is there a way to make medical school more affordable, as what has already been stated, that it is profit over people, paying for education is not a priority, the US government, even the AAMC, the match process is very expensive. How can states or government be motivated to aid in making medical education more affordable and AKA making primary care more attractive? Anybody have answers for that? That's a tough one. Thank you, Morgan.
I mean, I don't have an answer, but if the panelists want, I can give it a shot. I don't want to take over the panelists.
Go for it, Mark. I'm curious what you're
Please.
gonna say.
Yeah.
I think a couple things. I think Hannah said this earlier. A lot of time, something that I think is not well known is that medical students, because of the expense or the cost, excuse me, most medical students are from wealthy families. Over half. Over half of US medical students come from the top 20th percentile. It's extremely skewed. So it's essentially medical schools only for the wealthy. And I'm being a little dramatic, but that means, about 5% come from the lowest quintiles. That's tenfold difference. Now, what does that mean? That means, of course, people, lower income students, people from lower income families can't afford it. And yet, we know those individuals are actually more likely, at least our data suggests they're more likely to go into primary care, the thing we're talking about. And they're more likely to work in marginalized communities. Native American students are more likely than any other student to work in to do rural primary care, yet it's a tiny drop. So the financial thing is huge. Now, how to fix it? I think you've got to get people and schools to invest more in primary care. I mean, I put something in the chat that's about clinical primary care, but I think you've got to invest the link I put in the chat talks about some of our primary care tracks. Our primary care track students, they get their tuition paid for, so they don't have a reason not to go into primary care. Now you got to figure out that's one school. That's not enough. It's a very small thing. But you got to have a movement to get people to pay to invest in future primary care physicians. That is, make it possible for them to go to medical school. And then I think you've got to invest just in primary care services which we know are just woefully underfunded. Now, there are some states that are doing this. Rhode Island is investing 15% of all their healthcare spending has to be primary care by law. So they're actually, I think, making progress. But anyway, I think more awareness and more discussion. And that was probably too much, but thanks. That was not the whole solution, but
No, I thought that was really great. I thought the way you highlighted the disparity, just even in like medical students' background and like where they're gonna go practice afterward, like makes it really clear the like level of the issue that it is. And like to some people, the cost of like all these like MCAT prep, MCAT cost of the test, and like whatever, it's not that big of an expense for them. For some families, that's like they saved up the whole year just to take the MCAT kind of thing. Um, yeah. I also wanted to add that the Dr. Michael Fine is the one who kind of like started primary care for all Americans, and he's from Rhode Island, which is like kind of why this like state-based approach is like his thing. But I also really believe that it can work, so I'm hopeful. Fingers crossed.
well, I think again, public shaming helps. You need to again hold leaders accountable and make people understand how can they expect you to solve this problem when they're not spending any. This is America, as someone said earlier, right? It's capitalism. If you believe in something, then you have to put some investment towards it. But you're right. Rhode Island's a great example. The Millbank Fund is kind of a foundation that's trying to support states and other projects that are lifting up primary care as well. That's another thought or good idea or resource.
We have something in the chat from Nishmi. I recommend the Latin American School of Medicine in Cuba, also known as ELAM. They offer free medical school tuition to working class students in the US and around the world. That's really interesting. We are connected to a network of doctors who have trained there and are now practicing back in the US. Very interesting topic. I'm sure we could go on very long about medical school tuition. We know Albert Einstein tried to do free tuition. NYU did it first. However, their wealthy students increased, interestingly enough. So we need creative solutions, I'm guessing, even with the free tuition. I don't know if anybody else read those papers where they kind of talked about the free tuition.
Could you please link them? I didn't know the free tuition actually increased. Yeah, please send that to me.
The best analysis of this is in the Atlantic about 2 weeks ago, which looks at what happened
Okay.
at NYU when we went to free tuition, which
Tuition
what happened
free.
was the percentage of low income students actually went down, and the percentage of Black students went down, and I mean all kinds of things. And so it definitely doesn't work based on that initial. There you go. It's in the chat there.
Thank you. Thank you.
Perfect. Yes, this was the one. Is this the one? Rose Horwich. Perfect. Yeah. Beautiful. That
I'm
was,
so sad by that, but I like also can see that happening because it became so much more competitive.
I see. Oh, Christina. Hey, Christina. As a primary care PA, this career made it possible for me to serve my community in ways that medical school couldn't. Medical school was simply out of reach. I couldn't have managed for years without working. PA pathway provided realistic and accessible way. Same. Well, I'm really happy that we all discussed these different approaches. We are going to close the recording. Anyone is welcome to stay, but we should close out the session to respect everyone's time tonight. Thank you to our three panelists for coming out and speaking about them being themselves. We're so happy to have you in this space. We need you in these spaces. Thank you for giving our audience a bit of your time tonight. We really appreciate it.